This is a brief lecture about hyper and hypocalcemia. You know, a stable extracellular calcium concentration and proper compartmentalization of calcium are really vital to many physiologic and cellular functions. Hypercalcemia is defined as a serum ionized calcium above 5.3, and hypocalcemia is considered at the level of less than 4.4 milligrams per deciliter. Either of these high or low calcium levels can signal serious disease, or conversely, they might be found incidentally without any symptoms. So you just have to have that knowledge when you're looking at your patient and doing your assessments and really trying to figure out which labs to order and how to interpret those labs. Epidemiologically, hypercalcemia is caused by primary hyperparathyroidism, and it's the most common. It's in about 0.2% of all persons greater than 60 years old that present. An interesting epidemiological factor about hypercalcemia is about 20% of hospitalized persons with cancer have hypercalcemia, and 15% of patients that are hospitalized that are critically ill. Also, in contrast with the hypocalcemia, it is also even more so common. 18% of hospitalized patients, but 85% of ICU patients, so those critically ill patients. The pathogenesis behind our calcium levels is about 99% of the 1 kilogram of calcium in our body is found in the bones. The other 1% is left in the extracellular fluid in the soft tissues. So we really divide our calcium levels and issues into either parathyroid hormone dependent or parathyroid hormone independent, depending on if the parathyroid hormone is non-suppressed or if it's suppressed. So clinically, how do these patients present? Because our real focus is looking at in primary care ambulatory patients. And it's really influenced by a magnitude, and right now we're looking primarily at hypercalcemia, at that rate of rise of calcium and the acid-base balance within the body, and also the presence of hypoalbuminemia. They all influence the clinical presentation. So usually if someone's calcium is under 11.5, they're rarely symptomatic. However, when it is above that parameter, you're going to see neuromuscular, cardiac, and GI depression symptoms. And I want you to refer to page 1105 and just review those. With hypercalcemia, the physical exam is often unremarkable, but if it is remarkable, and there are findings with those levels above 11.5, you might assess an irregular rate in cardiac rhythm. You might also discover a neck mass from the parathyroid area and thyroid area, or a breast mass. Often we'll see signs and symptoms of central nervous system depression, which reflect in hypoflexia, changes in sensorium, muscle weakness, tremor, lethargy, and ataxia. Of course, severe patients presenting could even be stupor and coma, but those would be ones we were sending or see in the hospital or the ER. There could be flank tenderness and also pseudogout. So keep those in mind. Diagnostically, what we're doing in primary care is we're measuring those serum total calcium levels and the albumin. We also want to look at a fasting intact parathyroid hormone. I often will include a 25 hydroxy D level, vitamin D level, alkaline phosphatase, mag, phosphorus, maybe an ECG in the clinic, and sometimes add a chest x-ray. If I feel like I have to add a chest x-ray looking for a tumor, Usually those people are emergent and need to go on. But those are some of the common diagnostics. Differential diagnosis when you're thinking of hypercalcemia is really primary hyperparathyroidism. It's the most common in the ambulatory person, and the other is malignant disease. And if you have a patient or has been hospitalized and they have hypercalcemia, 90% of them have some form of malignant disease. So in my experience in primary care, primary hyperparathyroidism is what I actually ended up diagnosing, and from the presentation of the person with calcium. And a lot of the symptoms that I see are central nervous system. And they're blunted. I don't see a lot of just frank hypercalcemia, but I do see the blunted symptoms and have to include that in my differential diagnoses, looking at that parathyroid function and knowing which labs to order and making sure that's in my differential. So management of hypercalcemia is really tailored to severity and acuity. So if it's mild hypercalcemia, you advise to hydrate, maintain volume, and really looking at those medications that worsen hypercalcemia. That might be all that's required. And I think as nurses, we know that severe hypercalcemia is a medical emergency. I mean, those are really sick patients. There is a med, and I gave you a little snapshot right there, Sensipar, that can be used for hypercalcemia to reduce calcium levels. But the truth is, if it's caused by the most common primary type or primary hyperparathyroidism, surgery is the only cure. Now let's look at hypocalcemia, okay? The pathogenesis of that results from calcium loss or decreased calcium in the circulation. It's caused by inadequate parathyroid hormone or calcitrol production or resistance, either one, and or sometimes IV biphosphonate use. And then look at that third pathogenesis, vitamin D deficiency. Okay, so you have to keep those in mind when you're working somebody up. Severity, again, for hypocalcemia determines the symptomology. You're primarily going to see neuromuscular or cardiovascular dysfunction. Maybe you'll see muscle weakness, a complaint of cramping, tetany. If you see that, that's severe. Seizures, depression, altered mental status, and sensorium. The patient might complain of generalized fatigue. Now, that's a broad complaint. Congestive heart failure, bronchiospasm, and laryngospasm tend to really imply a poor prognosis. And interesting, people with hypocalcemia may develop cataracts. Your physical exam in a patient with hypocalcemia may reveal spontaneous neuromuscular irritability with hyperflexia of the deep tendons, and that's why it's so important for us to be checking reflexes. There is a couple of specific signs that we can do. So the two signs that you can do, physical assessment signs, is the Chvalstick sign, which is looking for contraction of the facial muscle where you tap the facial nerve near the ear. And then the Trousseau sign is a carpal spasm after occlusion of the brachial artery with the blood pressure cuff. So put the blood pressure cuff, you occlude the brachial artery for about 3 minutes, and you'll elicit a carpal spasm if it is a Trousseau sign. And again, that's hypocalcemia. Hypocalcemia patients might present with a Parkinson-like tremor. Cardiac-wise, you might see low blood pressure, impaired contractility, and bradyarrhythmia. And there's two eye signs, papilledema and subcapsular cataracts. So I think you just heard I said cataract formation and hypercalcemia also, so keep those in mind. Diagnostically, you're going to look again at that fasting intact parathyroid hormone, fasting phosphonate, magnesium, 25-hydroxy-D. You can review those. I'm most interested in you knowing about the parathyroid hormone and the vitamin D level, okay? Differential diagnoses. For hypocalcemia, you really need a good history. Have they had parathyroid or thyroid surgery? Could it be idiopathic hypoparathyroidism? And so no known reason, no known cause, or you can't identify one. And then that big one in your thinking, vitamin D deficiency. So management for hypocalcemia, again, it is all directed toward the treatment of severity. All symptomatic patients must be treated. However, and in a severe situation, those are treated emergently with IV calcium. But vitamin D is the cornerstone for chronic hypocalcemia. I know I'm really looking more at an acute look, but I want you to know that vitamin D is the cornerstone for chronic hypocalcemia. Education is very important for hypocalcemia. It includes diet, hydration, mobility, really keeping those bones healthy, identify foods to avoid, and then the family needs to be taught about signs and symptoms of hypocalcemia and when to seek emergent care as appropriate. Severe hypo or hypercalcemia needs emergent treatment, and they need to be sent to the ER. And with your chronic patients, I would let a physician evaluate them. Thank you very much. I just want you to take a moment and look at these mechanisms of vitamin D deficiency on this last slide. Thank you.